orchiectomy done. And brief of clinical history: the patient had a normal normal serum beta HCG marker, the serum alkaline phosphatase was normal, bit elevated NDH level. There was a circumscribed testicular mass, and it was measuring about 39 millimeter in largest dimension. Okay, so that orchiectomy, high inguinal orchiectomy was done. Now we have the section. So in this section we can see that there are testes around with the paratestis we have. So what is the structure? This is a X section from the epididymis, and we have this testicular mass, tumor tissue, and we have over here the surrounding testicular parenchyma. Okay, so first of area of interest, it is a well circumscribed testicular tumor. And now if we zoom in on the medium magnification, we can see this tumor is divided by thin fibrovascular septa. At areas they are bit more thickened than other areas, and we can see some bluish area. If we zoom in, they are nothing but they are lymphoid aggregates over here. Now we are in the tumor lobules. We can see the tumor cells appropriately in this magnification. The cells are polygonal. They have ample of clear cytoplasm that gives an indication that it may be having a cytoplasmic glycogen in it. The nuclear outline is quite well defined. They have a prominent central nucleoli, and the cell outline is quite different. There is no syncytial formation, and the mitosis and apoptosis are seen in this figure. At several areas we can see there is a strict squaring off of the nuclei. As we can see, there is a cornering of the nuclear outline. That is another helpful clue. And the septa the septa that contains inflammatory cells. As we can zoom in, there is a mature lymphocytes. Predominantly we can identify the plasma cells also. Then we have another septa that is having the cell inflammatory component. So altogether we have this kind of cellular proliferation. There somewhere we are getting this lymphoid aggregate. Even they can form germinal centers also. And we need to exclude the other possibility of any other component or any other architectural thing that can be there. Okay, so we are not identifying any different pattern. Moreover, it is showing the similar appearance in all the part of the tumor. Okay, now we have to go towards the periphery of the tumor to identify if there is any lymphovascular invasion per se. So be careful regarding the identification of this lymphovascular emboli, because it being a very well tumor, it can have a carryover. We can see this is areas of Leydig cell with ample of eosinophilic and very granular kind of cytoplasm. They are surrounding this tube and occupying the interstitium. The normal epididymis that we are seeing in this picture were in the initial section or something looking like this. They have a muscular configuration, and near the lumina they have a tall ciliated epithelium with brass border. Okay, and the epididymal involvement abscesses the tumor. So what do you think about this? Is this any spermatocytic lesion that is occupying this? No, they are actually the transactions or the kind of leveling happening in this. You can compare the nuclear character from the luminous aspect of comparing on neighboring tubules and with this. So this is nothing happening over there. There is no epididymal involvement. The tunica is all fine. Now you have to look at the tubules. They are showing this kind of monomorphic cells. They are lining the lumen in a very monomorphic pattern. They are kind of telling you that this is a GCNIS, that is a germ cell neoplasia in situ. Okay, so there is a GCNIS associated with. We have the pure morphology that have a Seminoma's morphology with this, though no other component, and the epididymis is free. So With this, you can say that I like to do some immunohistochemistry, mainly the CD30, CD117 and OCT3 and 4. That will be very good marker if they come positive. SAL4 is a general germ cell marker. They can come positive in any other germ cell lesion of the testis. Then another good marker is CD30. You should not expect CD30 in pure seminoma, and if they are there, it generally hints towards the embryonal carcinoma. Okay, and you can rule out another things like you can do like glycogen 3 or AFP if there is any another mixed component that will be highlighted, namely the Yorkshire tumor. Okay, sometimes you can get granulomatous reactions or a foci of sensitive trophoblast thing. They produces the beta HCG, so the tumor marker will help to do extensive sectioning. And as the tumor, as I have initially told, it is 39 millimeter, then obviously it is more than stage 1A. So for pure seminoma, the size criteria is important, and accordingly you need to TNM staging is done. Okay, so that is one important thing. Another spectrum you need to do consider in a differential is a spermatocytic tumor. The spermatocytic tumor have a kind of older age group presentation. They don't have this lymphocytic aggregate. Morphologically, you won't get this fibrous septa loaded with these lymphocytes and plasma cells. And remember that this CD117 can be positive in spermatocytic tumor, but OCT3/4 is not expected in the spermatocytic tumor. Rather, you will get a mixture of tripartite cell population, large cells, intermediate cells, and the small cells, lymphoid looking cells. So that will help you to differentiate from the spermatocytic tumor. Okay, that's all for this pure seminoma with germ cell neoplasia in situ. Thank you.